My name is Gustavo Marino, a second year here at the University of Central Florida. My project is a review of lateral canthotomy training and the efficacy of using mannequins during surgical training. Considering military populations, proper visual function is necessary for tasking tasks, including effective weapons utilization and aircraft flight operations. Any pilot or flight crew member would be grounded with inadequate visual performance. Ocular injuries represent a strenuous problem for service members and the providers charged with their care. In the military's medical surveillance monthly report for September 2019, a total of 16,021 medical encounters were due to ocular injuries. Additionally, 43,485 hospital days accounted for eye injuries as well, the third most of any type of injury. The proportion of head and neck injuries has been significantly increasing since the 19th century. Before, eye injuries accounted for less than 1% of all combat injuries. Since then, a steady rise to 2% during World War I and II, increasing all the way to most recently recorded 30% of battlefield injuries that required medical attention in Operation Iraqi Freedom and Operation Enduring Freedom. So a rise from 1% to 30% over the last 100 years. An increased use of fragmentary munitions, such as IEDs and frangible bullets, has been cited as the explanation for this escalation in prevalence. Eye trauma can be a serious problem. The orbit is an enclosed space with limited ability to expand. The orbital cavity is pyramid-shaped and can hold only about 30 milliliters. Therefore, when injury causes blood flow to increase within the cavity, the pressure can decrease perfusion to vital structures and damage the optic nerve. If this increase in intraocular pressure occurs within a short period of time and presents with features of vision loss, the condition is then referred to as orbital compartment syndrome. Research has shown that approximately 60 to 100 minutes of raised orbital pressure may cause permanent visual problems. The lateral canthotomy, which we'll refer to as the LCC, is an urgent, potentially vision-saving procedure to reduce intraocular pressure. The LCC procedures are relatively straightforward and honestly take less than 5 minutes to perform. The procedure occurs by cutting the lateral canthal tendon, which normally prevents eyelid drooping and forward movement of eye structures. So making this cut allows for more room for the eye to expand, blood to be released, and it alleviates the pressure on critical structures. While it's extremely beneficial, this procedure is rarely performed, and medical professionals rarely keep up with the skills to perform the procedure. A study done on EM physicians showed that 83% of them were able to diagnose OCS, but only 37% felt comfortable actually performing the procedure. Since this can be a vision-saving procedure, a way to frequently train these skills is necessary. Here in my project, I have identified 7 current trainers being used. As you can see in the poster, the ping pong model and the plastic container model all use paper material and plastic to mimic eye anatomy and a rubber band to serve as the lateral canthal tendon. These trainers are typically very inexpensive and very portable. They allow for hands-on training to practice the movements of the procedure. However, they lack the feel of real human skin. You cannot adequately simulate ocular pressure, and you can only use them twice before they have to be replaced. However, studies have shown that just being able to practice the procedure on these trainers significantly improve the trainer's knowledge and confidence to perform the procedure. Next, the stops and the synatomy models are both made of synthetic silicone material that mimics eye anatomy and the feel of human skin. So when you're making the incision, it gives the same resistance as human skin intended would. However, these models are portable because they only show one eye or both eyes, but they lack the rest of the head. The silicone block does not allow you to mimic intraocular pressure, nor does it let you inject fluid to do so. Again, they only serve for 2 uses. The porcine model uses real skin and tissue of a swine, which allows for trainees to find the actual lateral canthal tendon and make the incision and see the eyelid droop and release of blood or pressure associated with a proper procedure, which none of the other models mentioned so far are able to do. The disadvantages are that this model is resource intensive. Not everyone can supply multiple swine heads for their medical professionals to use. The anatomy and skin tension also differ in the swine. So trainees may get used to finding the tendon in the wrong place or applying the wrong amount of pressure when performing the procedure. A human cadaveric model, of course, perfectly mimics the eye anatomy, and fluid can be injected into the orbital cavity to mimic OCS and allow for visualization of a successful procedure. The feel and tactile stimulation perfectly matches that of a real-world scenario. However, not every training program would be able to allow trainees to use their cadavers, if any are even available to use. The final trainer, created by Sonalist, tries to address the issues of portability, recyclability, and the assessment of the procedure. Sonalist uses a silicon head with replaceable eye parts to address the issues of mimicking human anatomy, recyclability, and cost effectiveness. The head is preserved and the eye inserts are only $5 to replace, and the head is very mobile, very portable. The skin mimics real skin. One can inject fluid into the orbital cavity to resemble the intraocular pressure, and the lateral canthal tendon pops when cut like it would in the real procedure. The disadvantage of all the trainers is that they lack the true marker of a successful procedure, which is the patient regaining visual function and relief of pain. While all the trainers have advantages that may appeal to certain settings, the Sonalist trainer appears to address many issues that the others have. The main advantage of all the trainers is that just being able to simulate the procedure develops procedural memory and confidence in performing the surgery. In the future, it is important to incorporate these trainings into residency programs or for board recertification. A future study should look at the long-term retention of knowledge acquired from these trainers to see how often one needs to train in order to maintain a certain expertise level. Future studies should also take in various factors of the trainee, like their medical specialty and prior experience performing an LCC. The T-strap method has been suggested as an adjunct method to solidify memory of the procedure, since it would require the trainee to dictate their steps and discuss their clinical reasoning for what they're doing, instead of memorizing a series of steps. In conclusion, several trainers exist that can help medical professionals maintain their skills to performing an LCC. Some type of trainer should be incorporated into every training program to improve outcomes.